I'm always so excited to participate in, especially this particular course. And what I'm going to be talking about today is adoption of navigation in lateral access surgery. Last year I was a part of the residents and fellows course. And so for those of you who are there, you may recognize this, right? So from the Paris Olympics. And I made the comment that on the left, this is me doing lateral surgery, and on the right, this is Dr. Pimenta doing lateral surgery, not really needing a lot of stuff, which actually is quite pertinent because today I'm talking about navigation. And so when we talk about navigation, I'm going to start with the takeaway, right? And the takeaway essentially is that you can trust the nav in lateral access. And this is going to be for your surgical goals, increased efficiency, and decreased fluoroscopy. And it all comes down to trust, right? I mean, there was a point in time where I looked at this machine that does computer-assisted navigation, and I really thought to myself, can I really trust this in real time when I'm looking at an image? And naturally, there was a point where I didn't quite trust it, but who I could trust was Bill Taylor. And so I worked with Bill at UCSD, and actually he, amongst many of the people in here, are one of the kings of lateral access. And I'll share with you, we had a conversation once, and he pulled me aside, and he's like, Martin, I was peeking into the OR. I saw you were doing an OLIF, and I've been doing OLIF for a few years now. And he goes, what were you doing with the C-arm in there? And I'm like, well, what do you mean? And he's like, well, we're in like the 2020s, right? We have navigation now. Like, why are you using C-arm? And the thing is, he used the word C-arm, but what I heard out of his mouth was like a horse and buggy. It made me feel like I was in the medieval ages having an X-ray machine in there, and I just had this existential crisis about what I was doing. And so that's my path on adopting navigation. So as an overview, I'm going to go over two cases, a touch of literature, and then my own tips and tricks on how I got over my own learning curve in trusting the nav. So for the two cases, the first one, a 67-year-old coming in with low back and leg pain, lumbar ESI and facet injections used to help, not anymore. She's failed everything else, and she's neurointact, right? And you can see on the X-ray here, she's got a 4-5 spondy. And like Juan said earlier, 4-5 degenerative change, it's one of the most common things that we deal with. So you can see the spondy here. Centrally she looks fine. She's got lateral recess stenosis on the left. And so I tell her, look, you're coming with a spondy, you're symptomatic, I'm going to offer you a surgery. And so the surgery I offered was a single position 4-5 OLIF with posterior fixation. This is using the robotic system. The robotics has navigation built into it, right? And so the plan was to use that navigation system with that. She is positioned lateral, so you can see I use a flat Jackson, positioned all the way to the edge of the bed. There are navigated instruments that are used, right, to do both the screws are robot assisted, the surgery is navigated, and this is my first X-ray. So other than the two X-rays to register the system, this is the first X-ray that I take. And you can see here the cage is in position laterally, cage is in position on an AP image, rods are placed, and this turns into like a 2-hour and 20-minute surgery, right? So incision is made at 8:49, drapes come down at 11:08. So this becomes a very, very efficient surgery for a degenerative one-level inner body. And you can see here her pre-op and post-op. And again, she did very well. Now, case two, here I have a 59-year-old coming in with severe back and standing intolerance. And you can see here, he's failed all conservative measures. He can't really live with this. Neuro intact. And a little bit closer view looks, he's coronally off and sagittally off, right? So you can see his PI and L mismatch. Nowadays, we're looking into L4 to S1. We're looking into L1 PA, T4 PA. So all of these are off on however you want to measure his deformity. And a closer look, he has a more major fractional curve. You can call it primary lumbar curve. But whichever it is, he's certainly off. And then his MRI, top center is L3-4, bottom center is L4-5, and then the far right is L5-S1. So vascular anatomy is favorable on whatever you want to do. And of course, his CT scan here. So for him, I also offered him a surgery. For me, this is a 59-year-old coming in with adult degenerative scoliosis. And my plan was a stage surgery. So stage 1, L1 to S1 OLIF with a lateral ALIF. And then stage 2, the idea was a circumferential T10 to pelvis. So assuming that he's going to be corrected, it would just be PERC from the back. So he's also positioned laterally. This time he's in the center, right, since it's a stage 1, so I don't need him all the way at the edge of the bed. And in this video, I want you to focus on that screen. So an O-arm has been spun, and you can see here with navigation, I can essentially just mark every single level, right? So there's no fluoroscopy here at this point. And so for 5 levels, I can see where I enter at L1, 2, L2, 3, L3, 4, L4, 5, and L5, S1, mark those incisions, and then start the process of the exposure. Like Nima said, I also place K-wires in all of my disc spaces first, which we'll go over in the tips and tricks. But you can see the K-wires placed there from L1 to L5. And then I also dissect in my lateral ALIF. And you can see here, again, even with the lateral ALIF, and I'm gonna blow this image here, I can confirm that I'm at the center of the disc space at L5S1. So again, no X-ray that you would normally take to confirm that you're at where you want to be. After that, I go back, I place all the inner bodies. You can see here, I navigate from L1 all the way to L5. So 1, 2, 2, 3, 4, 4, 5. And then really, I shoot the X-ray for 5-1, right? So I do like to see that bone move. So I shoot that X-ray. That's my first X-ray to confirm all the cages are in place. So here are all the cages from 1 to 1 on lateral and AP. And then these are the incisions. Of course, we're in a lateral course, so all the incisions are always going to be fairly small. And you can see here on just the first stage, he corrects, right? That's the beauty of lateral surgery, where now what historically would be a very good open surgery can now become a minimally invasive surgery. And you can see here restoration of that lordosis with the lateral cages. And here, because of this correction, the idea is that everything from the back is going to be percutaneous. Well, transfascial, but minimally invasive. So you can see here a T10 down to ilium planned. This is done with the assistance of the robotics platform. I do a single incision, especially for my larger surgeries. Everything is transfascial. I do vertebroplasty my top levels. And then this is his final. I did put in a kickstand rod on that left just to make sure he was coronally in balance. And then you can see that correction, right? So here's his CT scan, and then here's his X-ray. You can see him put back into coronal alignment. But more importantly, what drives outcomes is the sagittal parameters. So you can see here all of his sagittal parameters, whether you do mismatch 4-to-1 or T4 L1P axis, they are all back in alignment, right? And so, with this, just some literature. I know Nima did, actually last year, I remember he presented a lot of excellent literature, and so I'm just gonna put it in a few. Paul Park really came about in 2015, and he described sort of where the ideal cage would be if you're navigating. He divided the disc space in quarters, so anterior 25%, middle 25%, and then the posterior 25%. When you're navigating, ideally that safe space is quarters 1 to 3, right? So that was sort of what he described. And then he presented his case series in 2016. This was the image back, again, 2016, 10 years ago almost, right? People were doing navigation. And it was 31 patients, 66 levels, 97% of cages navigated were in quarters 1 to 3. And again, more importantly, the concern is if there's anything ever unsafe, and he didn't describe any neurologic or vascular complications. I would say 3 years after that, this is the UCSF group, right? So with Dean, Praveen, and Shane, again, they found and described their experience using navigation in OLIF, 214 patients, 350 levels from L1 to 5. Again, 95% of cages within quarters 1 to 3. And also no neurologic or vascular injuries from this approach. Everyone's gonna have some dysesthesias on the left, but nothing that was specific for the navigation. And then the last that I'll show was Qureshi's group, 2023. They compared NAV with fluoro, so 49 patients NAV, 38 patients fluoroscopy, and they found no difference in their quarters, right? So whether you used fluoroscopy or NAV, whether they ended up in quarters 1 to 2 or 3 to 4, statistically, there was no difference. I will point out, though, that when you look at quarters 3 to 4, there were 4 levels that were posterior, right, versus 0 levels with fluoro, right? So naturally, if you're doing fluoroscopy, I don't think we ever rarely aim for that lateral 25%, but in fluoroscopy, nothing like that, but in navigation, they did find that. Still, though, they didn't find any difference in their complications or outcomes. And then anecdotally, in my experience, so OLIF 1 to 5, I've been navigating for about a year and a half now. And I have a med student pulling some of this, but sort of rough data, 60-odd patients, 114 levels. I did have a few, right, at the quarters 3 to 4, right? So I would shoot the fluoroscopy, and the cage was like a little posterior at 3 to 4. Sometimes I left it, sometimes I repositioned it. But more importantly, and the big question that I always had, I was never so anterior that I ruptured the ALL. I was never so posterior or oblique that I was in the canalar foramen. And so, my conclusion was that it was safe and efficient, and Bill was right. And so I continue to use navigation for this. So for the tips and tricks that I found that were useful in my own adoption of this, 3 tips and 3 tricks. So I'm going to tell you the tips, and then we're going to go over them in detail. First, in multi-level cases, I place all my K-wires first at every level. Also in multi-level cases, I place the inner bodies from cranial to caudal. And then lastly, you want to make sure the iliac pin is directed posteriorly so that the array doesn't collide with your navigated instruments, right? So here's step number 1. In multi-level cases, place the K-wires first. My concern was that if I did an entire level to its completion, and say I was doing 2-3, I went on down discectomy, and I put in that cage, I would always worry, what if the spine did shift? And now there's no way to know at this point with the array on the back. And so while the array and the navigation is still the most accurate, I will dissect down here to 2-3, place that K-wire, I'll come on out, dissect down to 3-4, place that K-wire in the center of the disc, come on out, and so on. And this way, it relieves the paranoia that I have that the navigation is changing in any kind of way. So I do recommend placing K-wires first, and then just going back to do your inner bodies and navigating that. Tip number 2, also in multi-level cases, place inner bodies cranial to caudal. So, I used to do multi-level cases from the bottom up, because I would do the 5-1 ALIF, that's the most difficult. Then I would do the 4-5 OLIF, which is a little bit odd because you're oblique. And so I'd do the hardest level and go higher. And so it was a change. But in this way, I was not quite sure if I ever believed that the spine moved up until I saw it with my own eyes. Because if you think about it, when you work from the top down, the rest of the spine is attached to disc space, facets, sometimes you're bone on bone, attached to the sacrum, attached to the pelvis. There's no way you're going to move that south. So the spine is always going to be more easily moved up, naturally against thoracolumbar junction and the rest of the chest. So always start from cranial to caudal, and you can navigate all the way down. And then lastly, you just want to be sure the iliac pin is directed posterior. When patients are in lateral position, in my first few cases, I would just place it in the iliac crest. Sometimes the brochures, depending on which company you use, will show diagrams with the pin up there. And so I found out the hard way that as I did that, my navigated instruments would collide with that. So when the patient's in lateral, just follow the iliac crest all the way back to the PSIS. You don't have to put it right in there. You can come a little bit higher and more lateral, but just make sure it's really far out of the way, and that way it's never an issue when you're using your navigated instruments. Now, 3 tricks. So again, I'm going to tell you the tricks, and I'll show you them in detail again. During retractor placement, right, attach the nav frame to the first dilator to direct and confirm your retractor direction. Next, for multi-level cases, place a K-wire into the cage after. I got this from Bill, actually, and so this was actually a tip that I found to be very easy to go back and reposition. And then if you're unsure of the placement, just leave the cage a little proud, right? It's always going to be easier to mallet in the cage with a few taps rather than backslap it out if you're unhappy with how it looks. So again, during the retractor placement, attach the nav frame to the first dilator. We don't have yet retractor systems that can be navigated, although many of the companies are designing this. Until that happens, you'll see there in the image, the retractor's down, all the dilators are in. With this particular company, you do have to remove one of the inner dilators to fit the nav frame. But once you put the frame down, as you can see in the square, you can then confirm that your retractor is placed in the proper position, which generally costs a few x-rays. So here, you can navigate that, make sure you're aimed in the right direction, and then navigate the rest of your discectomy and cage. Number 2, place a K-wire, right? And so here, you can see from L1 to 5, I have K-wires in at 1, 2, 2, 3, 3, 4. Invariably, and for me, I'm very neurotic. I like my cages to look as perfect as I can get them. And so now, with a K-wire there, instead of putting your finger down and trying to find that gap and find that cage, or putting a blunt probe and trying to find that metal, all you have to do is just slide down that dilator, open your retractor, and then do whatever you need to do to reposition if you're unhappy with how the cage looks. And then here, you'll see that if you're unsure, just leave the cage proud, right? So at 1, 2, the cage is slightly proud. It's off center. Same thing at, what is that, 3, 4? Sorry, 1, 2, 3, yeah, it's 1, 2, and 3, 4. And so in this case, it's much easier to just mallet that in and get it center. Again, I know this from personal experience, because if it's too deep, you get the backslap in there. Backslap is very strong, so you invariably just slap out the entire thing, and then you have to put it back in anyway, right? So if you're unsure, just leave it a little proud, and then you'll be able to mallet in to where you want. So in conclusion, again, I'll say that there are other applications. Inner body surgery is really the most common surgery. But again, I navigate my lateral corpectomies. Thoracic disc herniations, I think, are helpful to navigate, because all you have to do is spin the O-arm and you see the disc, right? So here, it mitigates a lot of the concern in being at the wrong level, because you just navigate and you see the disc herniation, and then you drop down your wound and trajectory and your retractor placement. But there are plenty of other applications in lateral surgery. For lateral inner body surgery, though, again, my conclusion, which I started with, you can trust it for your goals, for your increased efficiency, decreased fluoroscopy. We went over 2 cases, some literature, and some tips. Again, here are those tips and tricks. Place the K-wires first, place your inner body's cranial to caudal, put the nav frame posteriorly, and then at the end, navigate the retractor, leave a K-wire after the cage, and it's always easier to mallet it in. So, thank you.
Great. Can I ask you a question, Martin?
Yes.
Thank you for learning from all my mistakes, too. I appreciate that. Everything I've done wrong, I try to run back in and tell you right away.
Yeah.
I could tell you also, leaving the cage proud, I think that's really important, especially when you're navigating, because it's really hard to know where you're at. So I diligently measure it. And actually, I have a new thing I was going to tell you. I have the tamp made that has a little wing that sticks out from it. So you tamp, and then the cage can't go back past the end plate because it sticks on the side. So it's a really good idea. And in fact, you can use a curette, you can use any instrument you want that hangs out over past your cage. And then when you tamp the cage in, it hits the bone and doesn't push the cage too far.
Yeah.
Which works really, really nice. But I find the same problem that you have is the cage placement is the hardest thing for me, and I don't really know why that is.
Yeah, I mean, I think coming from fluoroscopy, my first expectation in using nav was everything was going to be perfect, right? And so I'll tell that to you up front. It's not going to look perfect. I remember, like, I've been using fluoroscopy for a while. You know, Bill said that nav is great. The reps say nav is great, and so I think to myself, this better be great. And I use it. And I'm like, this is like, I wanted a dead center, and it was forward at the front, right closer to the ALL. I'm like, this doesn't look fantastic. But again, the idea behind the nav is that it may not be super perfect, right? But you have all the other benefits, right? It's faster, and as you know, Bill would tell me at UCSD, X-rays are not free, right? You're going to accumulate them over time, and so the more lateral surgery you do, if you can offset some of that to make you safer as a surgeon and healthier, I think many of this is certainly worth it. Nima.
Sorry, Martin, can they hear me?
Yeah.
Okay, perfect. So I delved into this topic last year.
Yeah.
Paul Park's first paper was a hybrid, navigation and fluoroscopy. And I think Neil commented on this, that the error of navigation is not anterior posterior, it's up down cranial caudal.
Yeah.
and it's like 2 millimeters from what Paul Park was saying. 2 millimeters is end plate. End plate and a lateral means subsidence. So all the papers that say navigation is great, they comment on the anterior posterior location of the cage, which I agree with, but nobody comments on what is their subsidence rate with navigation. So, and then that's what we were talking about, that yes, the soft tissue navigation is perfect, but when you put your hardware in, you kind of like, you talk about paranoia, like I think I haven't gone over my paranoia. Maybe I have to take more Prozac. But I have to bring the Flora because I don't trust it at the end to not violate the end plate. I know the risks of having fluoroscopy over time accumulate. I mean, I buy the risk.
Yeah, I think I wanted to show, where was it? It was that CT. Yeah, so I have the same paranoia too, because the idea is that with fluoro, you can tell if you're subsiding, right? Because once that end plate subsides, like you're done, right? The whole point of the surgery is lost. And so I think, you know, some of the ways I've tried to get around it, naturally, when you're looking at the wound, you can see some of that disc. So much of it is feel, but unfortunately, it is still something that you give up, right? Because I've certainly done cases where I put in a bit of a, you know, I put in a trial, it's a little bit too big, then I put in the cage, a little bit too big. You're just looking at a computer screen, and then you shoot the fluoro and you realize, well, some of that end plate has subsided. The cage was just either too big or not. You know, the way I've gone around, these are, you know, the reasons why these cages look a little funny, they are custom 3D printed cages. And so I think, you know, I adopted them right at the same time. And I wonder if because these cages are a little bit softer and more patient specific, I've gone away from seeing some of that subsidence because there's less hard edges that may dig into the end plate. But at least with some of these cages, I haven't had as many of those concerns that I did on the earlier side using the off-the-shelf cages. All right, if that's helpful. Yeah, Zach.
Just a comment on the coronally tapered cages. Created a really nice coronal correction with that.
Yeah.
Do you have any tips on the best usage for those coronal tapers? I think I've often felt when we're doing these on, you know, this is, if we're doing laterals, especially on like a bow type C,
Yeah.
where you want to get a little indirect decompression, but you don't want to throw the coronal shift off too far.
Yeah.
Is that a potential usage for them? I haven't used the coronal tapers, but I've had some inclinations toward it.
Yeah, I mean, I guess in a way you could argue that this is also about type C or a primary lumbar curve. And I had the same concerns. And you'll see the bottom cages. And this has been a learning curve because I've been telling him to make that downside taller and taller over time. And what I did here, actually, I accessed, you know, L1 to L5 with K-wires, but I actually did, I think in this case, I might have done the bottom ones first, if I remember. This last, I did about type C last week where I did that. And so I accessed everything with the K-wires, and then I did the lower curves first, right? So that way I would see if I got the correction before I actually committed. But I think about the same thing because you can certainly naturally throw this person completely off to the wrong side. And so for the coronal taper cages, that's definitely been helpful to try and push them up on that lower side to avoid kicking them off to the wrong side.
It seems like you've inserted pretty much the smaller side first on those. Can you go? Well, I guess actually at 2-3 you went larger side first, but
Yeah.
does that take some extra care? You know, not to violate the end plates. I mean, it seems natural, right? The cage you have at 3-4. Okay, fine, you fit it in there and you
Yeah.
fix the curve, but you're kind of going backwards there at 2-3.
Yeah.
I mean, look, nicely done with no subsidence, but I just curious if there's any technical points on that.
Yeah, I mean, I think, you know, the technical points and the great thing about, I think, the lateral course is there's so many ways to do lateral surgery. Again, my introduction to lateral surgery was straight to OLIF. And I think with the OLIF retractors, typically there's more leeway to see because either you have their anterior psoas, and so in that way, I cut underneath the psoas and I make sure the annulotomy is very wide. Yeah. And so I think in that way, my annulotomies are at essentially the anterior 25% all the way back past to the posterior. And by that large release, I feel like I think I get more of a discectomy, at least in my own hands. And I think that's why the bones move. And I think that's why in this case, I mean, the cages A to P are quite large, and it's mostly because I'm inserting them in sort of at the front corner, and then they fit into the back. But that's the only thing I can think of that might be a little bit different. But yeah, I mean, I certainly think about it, especially when you're going from the open side and you're lifting. You know, I always go from the left, so whether I'm working on concavity or convexity, I always come from the left anyway, and so I haven't found that much of a difference. For the coronal taper, if you're coming from the convexity, naturally that larger side of a coronal taper is going to be that fat bulldog end, but it still goes in. I think it's just working it so that the disc space becomes horizontal, and that way, as the cage goes in, it lifts it to that horizontal. And that's the best I can figure.
So you're trialing to the larger side
Correct.
before you insert.
Yeah, so I still trial everything, and I trial it to the. I sort of measure it because with the cages themselves, I just look at what the trials look like to sort of match it, and then I'll trial it to that.
Question. So you often go from cranial to caudal when you put your cages in. If you're trying to fix a pretty severe flat back syndrome, do you put your OLIF first, 5.1 and 4.5, to get the maximum lordosis, and then go from the top down?
So if I'm doing this, I will still go from top down. I think I still assume that naturally, if I'm doing the lateral ALIF at the bottom, then I'm going to get the maximum that I'm going to get. And so, doing that first, I think doesn't change what I do at the top. Again, that also said, I rely a lot on the predictive analytics of things. Many companies now will help to simulate what the spine looks like based off of either the cages you do or the osteotomies you do. And so I admittedly rely on that, right? And so it's not perfect, but based off of that preoperative simulation, I know that, this is the maximum I'm going to get. And I always tell them to overcorrect at the bottom because we never get as much as we want, right? They will give you this beautiful plan, this beautiful design, and invariably it falls short. And so I always tell them to actually add a few degrees to the cage design or to the rod, assuming that the things they can't predict are the facets, right? What if they're hypertrophic? What if I actually don't release the disc as much as, the computer simulation prepares for? But I'll still do that at the bottom, right, at the end, assuming that I get that correction at the bottom. And I haven't found any difference or downsides.
Can I ask Bill Taylor, if in this case you would go from the left, second, can you comment on taping and navigation versus a more fixed construction? The difference makes sense or not to have, the difference between taping and doing multi-levels, if does affect navigation or not? And if you go from the top down.
Yeah, so thanks. I mean, Martin's the one who's really the expert on navigation. It started, but I agree with you. The problem is normally when we think about it, we all start at the bottom, right, and work our way up. And I go from the top down now too, specifically because it's farther away from the PSI spin. You can put another spinous process clamp in if you want to and get some correction. But I go farther away from the PSI spin, and I'll do almost all of these prone now, and I would have gone from the opposite side just because I think it would open it up a lot easier. These are cages from, I'm sorry, I'm blanking on the name of the company.
Carlsmed.
Yeah, Carlsmed. They're not just coronally tapered cage. They're specifically designed for that implant, and that's one reason why they go in so nicely. But it going from laterally, more direct lateral, or it would be hard to get in on that side. But I go from the top down, and I honestly put all of the pedicle screws in first. Mm-hmm. And like someone mentioned in the back, the biggest problem is the patient starts to sink a little bit as you go along, and so you lose the up and down when you're trying to do it. So, but that's a great result, and the idea of pre-planning it. I think if we're not doing that, then you're in real trouble. And I don't think it's wrong at all to use the unit or the preformed rod, because I find you get a lot of correction when you're doing that, especially when you turn the patient prone. and I think it saves you. And I also notice, if you notice your cages, people always talk about lordosis of their cages and what they're going to get. Those are not really highly lordotic cages. They're not hyperlordotic cages, but you still got a lot of lordosis because of the placement of the cage. So I think a lot of things goes into getting that lordosis too.
And again, for a case like this, it's 5 interbody levels.
Yeah.
If I were doing this with fluoroscopy, it's going to be at least, everyone tries to reduce it. In my hands, it's always going to be like 5 to 10 shots, right? I take a look at the center. I'm not sure. I shoot posteriorly. I swing around to the AP. I mallet it in, shot, mallet it in, shot. It's not perfect. Take another shot. I swing around to a lateral again. It's a shot. And that's at each level, right? It's a lot of fluoroscopy, especially if you're going down the path of MIS deformity or even just a lot of multi-level lateral surgery. And the fact that the total fluoroscopy, and this wasn't perfect, I repositioned and malleted in a few of these, as I showed earlier. The total fluoroscopy for this case, though, was about 10 shots, which is a large reduction in X-ray.
Yeah, I mean, also, but when we're using navigation too, I always remind people is the least you were getting less fluoroscopy time for the surgeon, not for the patient. And I think at some point that's going to come back to get us. I mean, 3 or 4 CTs in the same day, which I've seen people do in our OR, is a huge amount of radiation for that patient. I mean, I've seen them, as you know, they shut down the room sometimes because they've had so many CT scans in there. So we think about radiation to us, but at some point we're going to have to start considering radiation to the patient too.
Yeah. Great. All right, thank you.